Welcome back. We have a great agenda today. And so now I'm going to turn it over to the chair of the Risk Reduction Subcommittee, Joanne Pike.
Good morning and thank you. Just as a quick reminder, the Risk Reduction Subcommittee has divided our presentation. Instead of having one day to present on risk reduction, we have 1 hour 3 times during this year to talk risk reduction. So we get to, give you some more messaging and science at all of these meetings. And this time we're going to be focused in on place-based risk reduction opportunities. So the last time we were together, we talked about how we can look at the public health organizational system, whether that is state or community. We had some case studies out of Georgia and Wisconsin to really think about how are they utilizing risk reduction. Today, we're going to be focused in on how can we utilize places or systems. It's fairly common within public health to not only think about how do you use that at the state policy or the community policy level, but to think about it from a systemic approach and how we can utilize organizational structures to change conditions or circumstances for individuals within that. We're going to focus in on interventions today within the faith-based communities and hear about results of numerous risk factor-related interventions in that faith-based setting. Our speaker on faith-based communities is going to be Dr. Anna Maria Brenciano. She is a professor of psychology at Harvard Medical School and the director of Center for Health Outcomes and Interdisciplinary Research at Massachusetts General Hospital. And then we're going to turn to the workplace and how workplace environments and conditions might be structured to address risk. And for that discussion, we will hear from Dr. Phyllis Moen, who is the professor emeritus at University of Minnesota, where she has worked also as a professor of sociology. We're going to start, as I mentioned, with Dr. Brenciano, and we'll begin with you.
Great. Thank you so much, Joanne. Good morning, everyone. I'm truly honored to be here with you to discuss strategies for reducing dementia risks through prevention and the opportunity of doing so in faith-based communities. Next slide, please. I have no conflicts of interest, but I had the good fortune to have support for my research from the National Institute of Health, Department of Defense, and the Patient-Centered Outcome Research Institute. Next slide, please. So in our time today, I will start by providing a brief overview of dementia risk factors. I will describe the opportunity of prevention interventions for reducing the risk and burden of dementia. I will share the evidence base for dementia prevention intervention. And we will spend most of our time today discussing why faith-based communities are optimal for interventions focused on dementia prevention, and what is the evidence base for dementia prevention interventions in faith-based communities. And we will end with a discussion on strengths, limitations, and future directions for dementia prevention interventions. Next slide, please. So we all know that dementia is prevalent and costly, and the rates continue to increase. Importantly, dementia does not impact only the person who carries the diagnosis. We know that family and friends who provide unpaid care for persons with dementia are themselves at an increased risk for dementia. And we also know that dementia negatively impacts the emotional, cognitive, and physical function of the entire dementia dyad, the entire family system, as well as the social network. And emerging research, primarily in couples where one person has a diagnosis of dementia, have identified 3 main mechanisms that are associated with increased risk of cognitive decline in the caregiver or care partner. And these hypotheses are likely applying to the family system and social network as well. First, caregiving is stressful, and this stress impacts the cognitive functioning of the caregiver. Second, people who have similar phenotypes, whether protective or risky, tend to flock together. And third, couples share lifestyle and environmental factors that are either risky or protective. So these potential mechanisms of shared risk within couples, dyads, families, and social networks are also opportunities for prevention. Next slide, please. So while the main goal is always finding a cure for dementia, and we have made much progress over the past decade, particularly with the arrival of disease-modifying therapeutics, we know that these treatments are costly, they have dangerous side effects for many, and are primarily helpful for individuals early in the diagnosis, which is problematic because dementia diagnosis continues to be delayed for many individuals, particularly those in underserved communities. And we also know that there are risk factors for dementia. And the Lancet Commission took a lifespan approach and came up with a revised list of risk factors in April 2024. Some of these factors, like age and genetic risk, are non-modifiable. However, we now know that about 45% of dementia cases could be delayed or reduced by addressing modifiable risk factors across the lifespan. The most important risk factor in early life is low education. Most risk factors occur between ages of 18 and 65. And after age 65, social isolation, air pollution, and vision loss appear the most important risk factors. And understanding which factors are most important at which point across the lifespan allows us to prioritize addressing specific risk factors during the life period where they make the most difference. So maybe after age 65, it may be more important to address social isolation as a risk factor than maybe diet. And this review also confirmed that individuals with low SES, which tend to be individuals from minoritized racial and ethnic backgrounds, immigrants, and those in rural areas, are at the highest risk for dementia. Next slide, please. So addressing modifiable risk factors across the lifespan through interventions represents an important opportunity to cut down the rates of dementia cases by half. And these interventions can work at a policy level to reduce air pollution and head injuries. They can also focus on engagement in medical care. And then we have the lifestyle or behavioral interventions, things that address physical activity, diet, smoking cessation, and so forth. And these are opportunities for prevention, not only for dementia, but also for the many of the risk factors that are listed on this slide under engagement with medical care. So for example, we know that if we work on increasing physical activity, we are likely to decrease LDL, to decrease risk for diabetes, hypertension, and also help with healthy weight. What is also great about lifestyle interventions is that they are generally low cost and more accessible to individuals and also have few, if any, side effects. Also, these lifestyle interventions impact not only cognition, but also overall health and quality of life. Next slide, please. So what is the evidence base for dementia prevention interventions? Well, systematic reviews show that there is preliminary evidence for benefit. Most interventions tend to be multi-component, targeting more than one risk factor. Interventions are individual or delivered in group format, in person or virtual, and sometimes through digital platforms. And there are 3 large systematic reviews published and 40 ongoing trials, which is really exciting. One systematic review published in 2021 included 9 RCTs, 9 randomized controlled trials, and looked at prevention of cognitive decline or dementia and found small benefit for cognition up to 36 months. However, the review also showed high variability in dementia incidence. The second review, published in 2022 in JAMA, included 28 randomized controlled trials and found moderate improvement in global cognition in those with mild cognitive impairment. And the third systematic review was conducted by our group and published in 2024. It included 79 randomized controlled trials, which addressed dementia risk factors through mindfulness-based lifestyle interventions and found moderate improvement in these lifestyle factors. Next slide, please. So in sum, we have some evidence, but we also have a lot of work to do. We know that lifestyle behavior change is hard, and we know that it's even harder to maintain these lifestyle behaviors. We also know that dementia prevention trials are challenging to conduct, and the body of evidence thus far has limitations. First, there is variability in effectiveness of interventions due to heterogeneity. Also, few studies looked at long-term impacts, and this long-term impact on cognition is really important to assess, particularly when looking at cognitively healthy individuals. There is also limited attention to diversity and inclusion despite highest risk. For example, only 62% of the trials that I presented reported race and ethnicity, and 90% of those trials who reported race and ethnicity included primarily white individuals. So in sum, dementia risk prevention interventions require lifelong changes and must reach all individuals, including those from marginalized communities who are truly at the highest risk. Next slide, please. And this is where faith-based organizations or communities come into play. Faith-based organizations are uniquely positioned to serve as effective settings for dementia prevention interventions due to many factors. First, faith-based organizations are deeply embedded in communities and are often seen as trusted and credible sources for guidance and support. Many individuals rely on these institutions for health information, which helps overcome skepticism or resistance that sometimes happens with preventive health interventions. These organizations also align with the cultural and spiritual values of their members, and this alignment allows for tailoring of dementia prevention strategies in ways that resonate with the beliefs, traditions, and practices of their members, thus increasing likelihood of acceptance and sustained engagement. Faith-based organizations also provide regular and convenient gatherings where health messages can be disseminated, making it easier to reach diverse populations, including underserved and marginalized groups. They exist in urban, rural, and remote areas, ensuring accessibility to hard-to-reach communities. Faith-based organizations also foster strong community networks that provide emotional, social, and logistical support, which can motivate participation in interventions and support sustained improvement. These organizations frequently already have existing infrastructure, so things like buildings, communication channels, and volunteers, and this can be used to implement dementia prevention programs at a lower cost than when creating entirely new systems. There is also decreased need for marketing and outreach, which also reduces cost. Faith-based organizations have a wide-reaching influence, often overcompensating individuals across different age groups, socioeconomic status, and cultural backgrounds. And faith-based organizations often address the mind, the body, and the spirit in their programs, providing a natural fit for dementia prevention strategies that emphasize healthy living, mental health, and social connection. And finally, while typical dementia prevention interventions target the individual, faith-based organizations, because they are attended by families and communities, allow for opportunities to improve health for the entire family or communities, either directly or through ripple effects. Next slide, please. So what is the evidence base for dementia prevention interventions in faith-based communities? So I thought I'd highlight some of the systematic reviews available, including some of the lessons learned. The first systematic review is focused on hypertension management in faith-based settings. It includes 29 studies with Black and African American Christian adults. The studies used a variety of interventions, including education, physical activity, nutrition, body measurement, and blood pressure checks. The primary outcome was blood pressure reduction. Results showed a significant reduction in systolic blood pressure at 3 months and 12 months. However, there was no assessment of cognition in these studies. Some of the lessons learned mentioned in the systematic review include the importance of engaging faith-based leaders and aligning health messages with their religious teachings as a way of increasing adherence. And also understanding of culture and using community-engaged principles was considered crucial for success. Next slide, please. 2 systematic reviews looked at physical activity and diet. The first included 13 studies with underserved, primarily African American adults. The interventions were focused on religion and spirituality, and there was a significant improvement in physical activity and reduction of sedentary time, but there was no assessment of impact on cognition. The second review included 46 studies with African American adults. Interventions included healthy eating, educational workshops, cooking demonstrations, educational classes, And results showed, again, a significant improvement in diet, physical activity, and weight loss. Again, there was no assessment of impact on cognition. And across all these studies, there was no assessment on the mechanism of behavioral change. These studies highlighted the importance of incorporating spirituality within health interventions to improve outcomes, as well as the role of community support for behavior change. Next slide, please. Next systematic review was focused on 13 studies assessing obesity and diabetes prevention. All interventions were weight loss through various approaches. About 70% of studies showed reduction in weight. 60% showed increase in fruit and vegetable intake, and 38% showed increase in physical activity. Again, cognition was not assessed. And these studies tailored interventions to the cultural and spiritual context of the larger populations, and included active involvement of church members in program planning and implementation, which are considered key for success. Next slide. So I was able to locate only one systematic review looking specifically at cognitive health and dementia-specific interventions in faith-based organizations. The review included 27 studies with older adults. The intervention was cognitive health in the context of religion and spirituality. Outcomes included global cognitive functioning, memory, and executive functioning. And results showed that religion and spirituality are protective against cognitive decline, and that these results are explained by social support. The process of integration of cognitive health with religion and spirituality was found to be key for success in these studies. Next slide, please. So in sum, we know that most evidence-based dementia prevention in faith-based communities is relatively small due to a lack of studies that assess cognition. Most evidence comes from broader lifestyle interventions that target dementia-related behaviors, but unfortunately, the mechanism of behavioral change is not really specified. And there is modest improvement in health behaviors and clinical outcomes like blood pressure. Next slide, please. So as I mentioned, the studies in the systematic reviews I summarize have several limitations. First, there is heterogeneity in the types of studies included, which introduces confounds when making statements about improvements. There are also methodological limitations around the intervention design, delivery modality, as well as outcomes. Most interventions have short duration, and there is little attention to sustainability of improvement. Criteria are broad, and mechanisms of change are mostly not specified. There is also a significant focus on African Americans versus other groups. And while the African American population is an increased risk for dementia, and we should prioritize this population, other populations like immigrants, Latinos, or individuals in rural areas should also be prioritized. There is an underrepresentation of older adults, as well as men in these trials. And then in terms of results, while interventions show improvement in risk factors, the direct impact on dementia incidence or cognition is not known because it is rarely assessed. There is also limited attention to sustainability, to ensuring that programs remain in the faith-based organization when the study ends, as well as on scalability. Next slide. Nonetheless, there are many strengths and many lessons learned from this study that can help us think about future directions when designing interventions and programs for faith-based organizations. First, inclusion of clergy or lay leaders plays a crucial role in program promotion and delivery through enhancing trust as well as participation. We know that programs must be tailored to the cultural and spiritual context of the target population, as this helps with acceptability and behavior change. Social support is key, and group-based activities foster a sense of community and accountability, which are critical for sustained engagement. It is also key to integrate the new intervention within the existing church activities, for example, within Bible study groups or prayer groups, as ways to increase accessibility and participation. It is important to address structural barriers to participation, so things like transportation or financial costs or childcare or access to healthy foods. Many successful programs use peer leaders or lay health workers, and this can truly help with sustainability. And methodologically, ensuring that interventions are theoretically driven and that we understand the mechanism of change will be very important. Next slide, please. So future studies should consider assessing cognitive function and dementia risk reduction directly, rather than relying on proxy measurements like blood pressure or body mass index or self-report. We need studies that hypothesize mechanisms of action for lifestyle behaviors, as well as link lifestyle behaviors with improved cognition and reduction of dementia incidence, with both mechanisms and outcomes assessed. We also need to increase methodological rigor. We need a larger number of rigorous randomized control trials and longer follow-up periods to establish causal relationships and evaluate durability of effects. We need to expand our populations and include diverse racial, ethnic, and socioeconomic groups to improve generalizability. We also need to target older adults and individuals at high risk for dementia, as well as men, since most trials include primarily women. We need to conduct cost-effectiveness research to evaluate the economic feasibility of scaling up successful programs. We also need to consider technology integration. We need to leverage digital tools like apps and telehealth to enhance program delivery and monitoring. Technology can also help with sustainability of improvements. For example, we are now conducting an NIA-funded study in the Boston Black churches where we are testing a web platform to help older adults continue to engage in physical activity after an in-person 3-month intervention ends. And here we are also focusing on sustainability. We are helping churches to raise money to be able to sustain the web platform that we developed after the study ends. It will also be important to consider interventions at the level of the dyad or couple and family and take advantage of the interpersonal relationships as opportunities to support behavior change. We all know community partnerships are key. We need to start these partnerships very early. We need to make them long-standing, and we need to integrate community feedback across all stages of research. We also need to think more about innovations. And for example, health ambassadors could be church members that can be involved in lifestyle programs, can share information, can engage communities, and can also help with sustainability of improvement. And finally, it is important to take a lifespan approach and prioritize addressing the risk factors that make the most difference at a specific time point within the lifespan. Next slide, please. So I'm going to stop here. Thanks again for having me, and I'm very happy to answer any questions.
Thank you, Anna Maria. We're going to pause on questions. I failed to mention right at the top our structure. We're having 2 20-minute presentations followed by 15, 20 minutes of questions. So if you can hang out just for a minute, we'll be back for questions in a second. Dr. Moen?
Yes. Let me see if I can figure out how to share my slides, my screen. Give me 1 second here. End show. I'll end the show, and then I will begin the share. Okay, it's not letting me start the slideshow there. Okay. Well, one would think that paid work would surely affect dementia and Alzheimer's disease. But given that we spend most of our waking hours on the job, most days of the week, most weeks of the year, most years of adulthood, but there are no rigorous randomized field trials of working condition effects on mental ability. However, there is evidence that work plays an important role in shaping factors leading to Alzheimer's disease. But work is changing, and so may be its effects on risk reduction. I'm going to tell you what I see as the key issues that the evidence shows affects cognitive health related to work. First are the protective effects of ongoing education and learning. Second are the protective effects of social engagement. And third are the protective effects of a sense of control. Today, I'm going to talk about the dislocations upending both paid work and cognition, the research evidence, and what we need to know if I have time. First, with the dislocations, we are experiencing unprecedented technological, demographic, economic, political, and other upheavals affecting both work and cognitive function. People are living longer, they're living healthier longer, they're more educated, and they are working longer, all of which should affect cognitive functioning. But work is changing as well. Two economists say we're in the second machine age. The first was the development of the steam engine, which led to the Industrial Revolution. And that's the case where machines augmented our physical power. Second, now we're in this development of computers where digital technologies are augmenting mental power. Machine learning, AI technologies are mimicking the way humans think, learn, and perform, with obvious but unstudied impacts on cognitive functioning. As I said, there are few randomized studies of interventions, some natural experiments, and many observational studies, meaning surveys following people over time and trying to connect different aspects of their experiences with their cognitive functioning. A large body of evidence says that complex work is associated with cognitive functioning. In other words, use it or lose it. And this has shown that higher mental and social demands of work are associated with higher levels of initial cognitive functioning, but appears to have no effects on declines with age. Physical work demands, by contrast, are negatively linked to cognitive functioning. But given that work matters, especially complex work, is retirement a risk factor? And a study finds that in low complexity jobs, all retirement pathways, no matter when or how you retire, are associated with accelerated cognitive decline. But in high complexity jobs, retirement is not associated with cognitive decline, and returning to work has modest improvement in cognitive functioning. There's another large body of evidence on job strain. This puts high demands and low control on the job as reducing cognitive functioning. And studies have shown that job strain, and especially low job control, is linked to poor episodic memory at retirement and more decline after retirement. And these are people that I've studied. This is Susan, who I've interviewed, and she shows that retirement is an uncharted part of the life course. She recently retired and said, the course of action was unclear. I felt paralyzed. I liken this to living in a black and white postcard. Nice picture, but dull, cold, and inhibiting. However, some studies suggest that retirement reduces the effect of job strain, that in a sense, you're leaving all the stress of work, and that may well slow the rate of cognitive aging. So we have to remember that retirement is sometimes a welcome choice for many people. This is Linda. I got exhausted where at the job you'd go around the school to many of the classrooms and work with children. And it was a lot of walking. It was a heavy schedule of children and dealing with many teachers. She was a teacher's aide. And I think physically I got worn out. I have a knee with arthritis that would really provoke that by the end of the day. So for Linda, retirement may well promote better well-being and cognitive function. But we have to recognize that there are unequal and gendered pathways to retirement in the US. Black women and men are more likely to follow disability pathways, leaving the workforce earlier with possible cognitive impacts. Older white women generally and white men in their 60s and early 70s are more likely to follow part-time paths, which may be less stressful. Black and Hispanic women are more apt to move out of the workforce in the 50s and 60s for family reasons, and this for caregiving, and this is understudied the effects it has on their cognitive performance. The second set of evidence has to do with particular job conditions that provide risk and protective factors predictive of Alzheimer's disease. And I was pleased to participate in the Work, Family, and Health Network, an interdisciplinary study from universities across the country, funded in part by the National Institute of Aging and NIOSH, as well as other supports from other agencies and foundations. What we wanted to do in the Work Family Intervention was give the worker a greater sense of control and supervisor support. And what we did is we had work groups, teams, reconsider where, when, and how their work is done. Our goal was a dual agenda to aim to make work more effective and efficient, but also sustainable for all employees. What we found, we studied two groups, a Fortune 500 company and long-term care nursing home facilities. In the IT corporation, we found that this intervention increased over 6 months and then 12 months, increased job satisfaction, decreased burnout, stress, psychological distress, and work-life conflict, and provided modest increases in sleep duration and quality, reduced turnover, and among people ages 50 to 64, it delayed the anticipated date of retirement. In nursing homes, we found reductions in stress and psychological distress, but only among people who were caregiving at home as well. They were caregivers at work and at home. And we found a reduction in smoking overall in nursing homes. And in both the corporation and the nursing homes, we found the intervention improved cardiovascular risk scores for those with higher baseline scores. Older employees experienced significantly larger reductions in cardiovascular risk. I want to tell you about two natural experiments on new ways of working, because we need to look not only at what was, but what is coming down the pipe. One was a study of the pandemic catalyzed remote work and retrenchments, as employers insisted that many employees come back to working on the job. We found positive effects of remote and hybrid work compared to the negative impacts of going back to working at work. Going back to work meant higher job demands and reduced schedule control. Remote hybrid work may also bridge some of the gender and racial disparities in job conditions, because Hispanic and Black women in particular benefited from working remotely or in a hybrid way. And when they had to go back to work full-time, they saw a decline in decision latitude and schedule control. And Hispanic women experienced greater increases in job monitoring, people watching what they're doing and tabulating it when returning to work. Going back to working at work also increases white workers, but reduces Black men's sense of coworker support. In other words, Black men feel more supported by their coworkers when they're not physically with them all the time. And we found that many returning to the workplace following the lockdown prefer to work at home. This is the orange bars, and at every wave of our study, for men and women, nearly half of those who returned to work said they would prefer to be working at home. The second is a natural experiment. I'm involved with a group that's looking at the 4-day work week. This is not 4 days and 10 hours each day. This is 4 days, 32 hours a week, and full-time pay. And a number of especially small companies are trying this out in Europe and in the United States. What we found was that work hours truly did decrease for those companies initiating this experiment. And with it came a reduction in stress, a sense of more time to get their life done, their personal life, a sense of more efficiency at work, greater job satisfaction, and a greater sense of control. So this is on the cutting edge of changes that we're now seeing in the workplace. We don't know what the effects are on cognitive functioning, but I would think that these positive effects and well-being and a sense of mastery has positive effects. What we need to know, just like Anna Maria, I think it's important to have a life course focus, a life course intersectional focus on time, timing, and trajectories. Timing is when in the life course do certain characteristics matter? Does it matter in what you're doing towards the end of your work career, throughout your work career, what you're doing later in life as you stop working? What matters and when? Second is historical time. We need to know how are the changes in the digital, temporal, and spatial organization of work and retirement affecting cognitive ability and decline. One way you could think of it as getting rid of the routine tasks would increase the complex tasks and therefore increase cognitive functioning. Finally, we need to know about trajectories. How are the protective factors of education, income, wealth related to working conditions and job durations? And does this produce a reverse causality? What is the causal relationship? We also need to look at bridge jobs and volunteering. This is Sarah, who I interviewed, who was a CFO of a large corporation. When she retired, she started teaching young kids to read. What I discovered, what I love working with the kids were so generous with their trust and affection. I think that I will be a tutor for as long as they will have me. So I end where we began, the protective effects of education and ongoing learning. Job complexity means you're problem solving, you're always having to learn. Ongoing learning and training. Someone mentioned ageism. A lot of times older workers are not trained. They're assumed to be on their way out. And yet training is an important component of cognitive functioning and cognitive reserve. The protective effects of social engagement, relationships, and ongoing engagement in work and volunteering that produce a sense of meaning or purpose. And finally, the protective effects of a sense of control, the misfit between preferences and job conditions, and between work status. Do you want to continue working, or are you forced to for financial reasons? And the ability to change situations that you find untenable. The challenge is that the bonus years of health, or else living and working with chronic health problems, plus new technologies and uncertainties about the future, require new visions, reimagining life paths and possibilities of work and learning. Also, social inventions. We're very good at accepting technological inventions, the latest iPhone, but we need social inventions, new ways of engaging, connecting, learning, and living. One of the things I've tried to do with limited success is get my institution, the University of Minnesota, to adopt ongoing education so that people of all ages are in the classroom. So this is uncharted territory. We need new templates of ongoing voluntary work and challenging, rewarding paid and unpaid work and other activities. The positive thing is that times of rapid transformation open up new ways of framing and organizing paid work, education, occupational paths, care work, life courses. This is the potential to design existing and redesign existing structural arrangements and investigate the unintended and intended consequences of these natural experiments. I didn't say natural experiments are those that would occur whether we study them or not. And companies are always changing things. We need to find ways of studying those. So this is a time of uncertainty, but also opportunity and something immensely modifiable, and that are the conditions of work. Thank you.
Thank you, Phyllis. And thank you to both of you for incredibly thought-provoking presentations about how we can think about both faith-based and the workplace as potential avenues to intervene for risk reduction. So we're going to open it up for questions, and if they're both to those in the room and also online, certainly. And I always have a couple questions in my back pocket in case there's none here, but we've got Adrienne with an early entry.
Thank you. Both of these are great presentations. I wanted to focus first on the one by Anna Maria. And when you talked about recommendations for the future in terms of further research for risk prevention in faith-based institutions, one of the comments was looking for outcomes. And we know, especially with hypertension or working with different populations, trying to follow a population long enough to get outcomes is part of the challenge. And those types of research would still need to be funded too. And so I think about some of those that are in the faith-based communities where you have people who are there over a lifetime, and some of those may be more amenable to long-term outcome studies. Where would one go toward getting funding for those types of long-term outcome studies that are based in a faith community? You may have that answer, or it may be some of our colleagues at NIH or others who might be able to comment on how you would get that type of funding.
Yeah, I can get us started. I really, really appreciate that question. I don't know if we have, available funding structures, for this sort of longer, prospective studies or even intervention studies where we have the long-term follow-up, which we really, really need when we're talking about cognitive health. I do think, it is an incredible opportunity to think about developing some new funding mechanisms at the level of the NIH to support, this type of studies, maybe starting with, I think that the structure that we have right now is we write an R01 and then to write the next R01, it usually takes a year if we're lucky, or maybe two. And so figuring out some mechanisms where, we get that first R01, and if things are going well and we meet certain benchmarks, we can immediately transition, to getting more funding to allow for, follow-ups down the line. But I definitely am really curious to see what other, suggestions folks on this Zoom have.
And I bring this up because when I look at the national plan updates and research, they talk about the need to follow more cohorts and engaging more cohorts into risk prevention and other types of studies. And you have identified through faith-based communities important cohorts that will be followed over a period of time. So can I throw that question to our colleagues at NIH to make a comment on the feasibility of any of that?
This is Richard Hoda. Certainly happy to comment. I hope that already you've been in touch with program officers at NIA, among other institutes, and they've been helpful in response. It certainly is, as noted, an area that's of interest. And the best information we can provide is to please take advantage of the outstanding program staff we have who are very interested in working with you. I hope it's been the case or will be.
Thank you for that answer.
Any other questions? Rhonda?
These were excellent presentations, very informative and thought-provoking. And so one I have is for both of you, just in terms of, I have concerns about the quick, rapid changes we're seeing in workforce and use of AI. And the displacement, yes, it can create less redundancy and less reliance on tasks that are routine. But I also wonder about who's going to be left out. And the very populations that are already at increased risk for dementia being the ones that are potentially could be a higher risk for the rapid transformation ahead of us. So just welcome your thoughts on the equity lens toward our workforce, in particular transformation.
I thought Anna Maria was going to answer first. Yeah, I think that this is an issue. There are groups that are definitely at risk, but they're also the ones most likely to do the routine work. And having that lifted, the key is ongoing training and learning. And if we have that, if we don't think of education in the first third of life, if we think of education throughout the life course, that we always are going to need to be upgraded and have skills, and sort of remove any fear of that by just incorporating it in. This is the way we work. We go back to school, we retrain. So making that possible, making it feasible to easily go back and to modify institutions of higher education where you can get that kind of training on the job, but also in higher education. So reimagining not only work arrangements, but also the arrangements of education. You know, everybody has, with every new innovation, they've said people are going to lose their jobs, and they did. I mean, the people who were shoveling before the steam shovel lost their jobs, but they went on to do other things. And so every technological innovation has really produced more jobs in the long run. So I'm cautiously optimistic. I really do think it's going to be a difficult time for some, but also an opportunity for really creating jobs that are interesting. My first job I worked at as I filed insurance forms. I filed from MA to MT, and all day long. And sometimes when somebody wasn't there, I got to do the B's instead of the M's, and that was exciting. I mean, thank goodness nobody does that anymore. So I think that what we're going to see are more interesting and complex jobs. It may be a little time of transition and bumpy, but I do think there'll be better jobs and more aligned with what people want to do, less physically demanding.
I really appreciate that answer, Phyllis, and I completely agree. You know, I also think, and this was mentioned earlier today, we do have this issue of ageism and maybe putting limits on older adults. You know, we see this with all types of technologies, and in my work and the work of others, we definitely see that, older adults are actually excited about technology. They want to learn and they want to sort of shift and, do other things. And so, I think that that'll be an important problem to address, what is the mindset in the workplace, and, are we willing to put in, services or, support for older adults or just adults in general as AI will take over a little bit, so that they're not left behind. And this is an even bigger problem when we're talking about minoritized populations, where already there is a digital health divide. And I see Susan has her hand up.
And I applaud this group for looking at risk reduction, not at the end of life, but throughout the life course. That really is important to see, how did you get there? Most of the studies looking at adults in the health and retirement study, they start at age 50, and then they look at decline. But the biggest effects are at baseline. The biggest disparities are already there before you go on down. And so we need to figure out what's happening earlier in the life course.
Susan?
Thank you. Thank you both for your presentations. Great spotlight, and it makes me think of the role of community health workers. And I was happy to hear Erin Long speak to the upcoming ACL grant opportunity. In California, we currently have a grant where we're working with community health workers who are helping assist upon diagnosis and really helping with those initial first months to help with navigation. And I see that as a role, also a big emphasis on peer specialists in our behavioral health systems, but an opportunity for people in our faith communities to be compensated for their lifelong learnings and wisdom and expertise and connections that they're providing to their congregations, but also an opportunity for older adults, many who have been caregivers, to family members who can be of help to other community members and to be compensated for that work. So I see community health workers as something that straddles both presentations and something we're very excited about in California.
Susan?
Yeah, could I say something of the family care workers? People leave their jobs because they can't manage both. They can't manage both. And they want to continue doing something, but there's just no scripts out there for them. So we need to provide those opportunities, not full-time necessarily, part-time, part-year, whatever, to give people a chance to be engaged in paid or unpaid work.
Thank you. Any other questions? Arlene?
Thanks for these wonderful presentations. And thinking about the opportunities there, both in the workplace and in faith-based communities, because what we really need is a healthy aging ecosystem that links it all together. And as I'm listening to you, I'm thinking about like the work on whole health and the work on age-friendly communities. And have you done work, or are there people doing work incorporating this so that all these efforts are aligned?
I would say, based on the response so far, it's an opportunity for us, Arlene. But Phyllis, did you have some thoughts too?
I thought Anna was going to answer first. Anna?
So I think that we are, conducting research still pretty siloed. I'm, sort of not aware of efforts to, bring someone to, all these initiatives together. But I'm curious if Phyllis or other folks on the Zoom have additional thoughts.
Yeah, well, I do think it's the total health focus, because cognitive decline doesn't occur in isolation. It's associated with physical and mental health. So I think more broadening the focus to include how these coterminous changes play out over time is important. And there are people who are funded by NIA in particular that are doing that are looking at how they're all related. That's what I know.
Yeah, and to sort of follow up on that, Phyllis. I think a lot of the times when we intervene, on one factor like physical health, we see, improvement in emotional health and cognitive health as well. Some of the work that we're doing is at the intersection of chronic pain and cognitive decline, for example, because we know chronic pain is a risk factor for challenges in cognition. So I really appreciate that, this opportunity to look at these outcomes together.
Any other questions?
I would say that from the conversations here and with Arlene's comment, how this really encompasses whole health. And as there are states out there that are starting to work on their state plans for aging, you have really identified two other groups who need to be at those tables. So thank you for your presentations.
And just another quick thank you to Phyllis, Anna Maria, for the time that you've given the advisory council today, and certainly your willingness to be here and join us. As we come back together in April for the last 1 hour risk reduction presentation, one of the things that we have been talking about on our subcommittee that will be a natural transition to that presentation, if I can give a sneak peek, is around interventions that we have learned in other chronic diseases, and how do you bridge the gap between research to reality at the community level, and what can we learn in that interplay. So we will spend that last session on bringing this to life at the community level, which I think is a great connection to that last question from Arlene, as we think about building more capable communities to handle not only risk reduction, but the full life course of dementia. So thank you all. And the Risk Reduction Subcommittee will see you again in April.
Thanks for that handoff, Joanne. Hi, everyone. It's now time to kind of move on into the remaining agenda for the day. And that is under the auspices of the Long-Term Services and Support Subcommittee. And again, I'm Helen Metzger, and I'm chair of that committee. And on behalf of all of my committee members here today, I want to welcome you to today's session. And that will be under the theme of the needs and successful programs addressing dementia in underserved communities. Now, the scope of long-term services and supports is quite broad, as it is care, whether paid or unpaid, provided across a very long spectrum. It covers in-home, it covers community-based settings, and also facilities such as nursing homes. In-home and community-based LTSS programs help people living with a dementia diagnosis to kind of maximize their independence by first focusing on their needs related to their disease, helping them plan for the future, providing support of their activities of daily living, and offering help and encouragement to their chosen care family, which can include training, counseling, respite care, and much more. We, as the LTSS members of the Napa Council, represent the interests of those in the U.S. who live with the diagnosis of dementia and their care partners. And we strive to create home and community-based programs side by side with our federal partners, so that all impacted and continue to live with purpose, safety, and with the highest quality of life for as long as possible within their chosen environment. During our LTSS presentation last year, we showcased the needs of those with young onset dementia, those individuals under the age of 65 living with a diagnosis, those with intellectual disability or Down syndrome, who are at heightened risk, and those who are on the margins, whether unhoused and incarcerated. But today, we are taking you to communities far and wide through this vast country, from near the Arctic Circle to Southwest Texas and places in between, each addressing the needs of a unique population. Our presenters will be sharing their experience, whether personal or through studies and programs that they have instituted within villages, towns, and cities that speak to the needs of the LGBTQ+, Native Alaskans, Vietnamese Americans, Black and Latino communities. We will learn from their experiences and the outcomes of their work. We will also hear of the gaps still present, and those will inform the next 10 years of the National Plan for Alzheimer's disease. So now I'd like to welcome my fellow committee member, Brother John Richard Pagan.
Thank you, Helen. I apologize first for not being able to be there. I'm unwell today, so please excuse the video. My name is Brother John Richard Pagan, and I am a member of the LGBTQ community and a military veteran receiving care through the Veterans Medical System. In August of last year, I was given an opportunity to participate in a Global Brain Health Institute initiative called the Walk the Talk for Dementia, where I walked 44 kilometers in 4 days, followed by a 2-day symposium where I spoke to a room of folks at a global level. As I ended my share there, I can recall saying that I do not want to have to return to the closet in order to receive long-term care services through the Veteran Services for in-home care and eventually assisted living and memory care. That for me was a scary statement. And I'm not alone. Long-term care in general is a scary process. As I live further into my diagnosis, I am already seeing my life challenges increasing in ways that I had hoped would not take long, that I had hoped would take longer. In one support group, we cried as we shared the fears we each have as we progress. But a part of those fears include what happens to me when remaining in our homes is no longer an option. I have taken this question very seriously. I have seen what hate looks like when people do not accept sexual orientation and gender identity. It was a lack of acceptance that gave the military permission to look the other way when I was verbally and physically abused while I was serving. The same lack of acceptance was the same lack of acceptance that gave the military permission to remove me from service because they thought I might be gay. Since then, I have had medical doctors ask me odd and inappropriate questions such as, did you play with dolls as a child? An actual question asked. And I've sat in waiting rooms where, while the television displayed local news, suddenly discussing the local Pride Festival, with veterans spewing hate at what they say, what they saw, and what they believed. It is no wonder I personally fear going into a veterans assisted living facility. I even fear a veterans services nurse coming into my home. Will I receive the same level of care that someone who is not LGBTQ receives? Will I be respected as an individual? I hope that I am treated with the same dignity as any human being, and yet I also want to be my authentic self. The reality is that long-term care in live-in facilities is regulated at the state level. There are no federal guidelines to ensure proper care in assistive and memory care facilities. Private care is a profit-focused business that corporations are getting into with little concern for patient care. And there are very few programs that specifically focus on the LGBTQ community's needs in long-term care. Even if you can find a place, the VA is less likely to collaborate with these community-based programs if they only serve to offer services to the LGBTQ community. which means no financial support to the veteran. Everything now becomes out of pocket, and like many veterans struggle to afford private insurance. So then what happens to me when I require greater long-term care? I want to find a place that I can trust to accept me as me. We need to do more to ensure long-term care services to all people, and that includes the LGBTQ community. Thank you for letting me share.
JR, thank you. To hear your story and the indignities that were presented to you really brings it home that we need to be looking at how we can address the needs of all. And whether gender-based or whether a different population of any variation, we need to be addressing them. Thank you so much. Now we're going to move on to Dr. Jason Flatt. Hopefully he is available online.
Yeah.
And we'll talk a little broader and deeper into this topic.
Thank you so much. Can you hear me? All right. I'll go ahead and share my slides. Presenter review. Are you seeing my notes or the correct version?
Correct version.
Okay, perfect. All right, so I wanted to talk with you a little bit about the needs of the LGBTQIA+ community, especially in terms of Alzheimer's disease and related dementias. And I'm going to focus a lot on the research and what we currently know, as well as point out some gaps in terms of what work is still needed. So my hope today is I want to get us on the same page with terminology of what we're using, what the field uses, build in a little more of why inclusion matters, both historically, but the current social context in which LGBTQIA+ people are living in, especially those living with Alzheimer's and a related dementia. Leave you with some of what's the current state of the research. What do we know in terms of either prevalence or concerns for the community? Always like to leave you with tools and share some of the progress we're making around ensuring inclusion of the community. And the way that we really do that is to ask about sexual orientation and gender identity. Share with you a little bit of the work that I'm currently doing that I can't share with you exactly the results from that, but I want you to see what will be coming and then leave some time for questions and answers. So I want to start off with some language. And so really in 2016 is when the National Institutes of Health, specifically the directors of the National Institute for Minority Health Disparities and ARC, designated LGBTQIA+ communities as a health disparity population. And why this matters is that it created unique emphasis around the need for research and recognition of health disparities, especially in terms of Alzheimer's disease and related dementias. So in terms of the language that we use from the federal government is the term sexual and gender minority. Whenever I say these terms, I always want to point out that this is not language we use with our communities, so they often do not know what the term sexual and gender minority means. But a sexual minority, this represents an individual who may self-identify as asexual, bisexual, gay, lesbian, queer, or they use a different term, but they do not self-identify as heterosexual. A gender minority represents an individual who self-identifies their gender identity or gender expression as not aligning with their sex assigned at birth. So this could include transgender people, non-binary people. It also includes often communities from indigenous backgrounds, so the Two-Spirit community, as well as in this language, intersex people are considered a gender minority. It's important to note, though, that intersex people are born with differences in their sex development, and it's often not an identity. but this is where gender minorities fall. In terms of sexual and gender minority, it's also important to note that you could be a sexual minority and or a gender minority. So it is possible you could identify as transgender as well as bisexual. Other terms you will hear in terms of comparison groups is the term cisgender. And this refers to individuals who their gender identity aligns with their sex assigned at birth. When we're thinking about data collection, it's really important that we often ask sexual orientation and gender identity more than once. Sexual orientation and gender identity do evolve over the life course, but when we ask this, we want to be asking these questions during a time when we're asking about demographics, about people's identities and backgrounds. I love this image because it just represents the diversity of the language and terminology that our communities are using. Today, I'm using LGBTQIA+, but it's important to note that the language is evolving and it's quite diverse. And so a piece that I always recommend is when you're working with communities that you use the language that they use to self-identify their sexual orientation or gender identity. It's also important to note when we're working with older populations, some of the language is loaded. It's been used to harm communities. So for instance, the term queer can be really triggering for people. And so it's important that you really do some work in using language that the community endorses, or if they correct you, then you make that quick correction. All right, and so these are really important, but it does represent a very diverse community. I also like this image from the Trans Student Educational Resource Group, the Gender Unicorn, because what it represents is really that people's identities fall on a continuum, whether we're thinking about their gender identity or expression, their sex assigned at birth, right? Most of the forms today are all binary, saying male or female. But as I've shared, intersex people are born with differences in their sex development and may not fall into one of these binary categories. Often people are like, oh, well, that's very rare. Well, it actually represents about 2% of the population, or they say as common as people with red hair. As well as the language is evolving, and we're going to continue to see this, especially with our younger generations that are endorsing diverse language. I will admit to you that some of the terms in this word cloud I could not define for you correctly. The language keeps changing or how it's defined. And so the call that I ask for you today, and I appreciate you letting us be here to share, is that you are open to using the language that the community uses, as well as practicing cultural humility around your openness to learning and really self-learning and not expecting communities to teach you what the language means. So why does inclusion matter? And I think that, you heard from John just a moment ago about sharing about, right, the historical impacts of the community. And so a major issue is that many LGBTQIA plus people who are older grew up during a time where rights were not shared equally across. So it was not uncommon in the 1960s for the police to raid LGBTQIA plus spaces. You could, if you were arrested, often either for dancing with someone who was considered of the same sex, or because you were wearing clothing that did not align with your sex assigned at birth, you could be incarcerated, as well as often your image would be published in your local newspaper. This would have huge impacts in terms of being ostracized by family and friends, losing your job, losing your housing. And so many of the privileges that people enjoy today, many LGBTQIA plus older people did not have these protections or opportunities. When we think about it historically, I just give a quick snapshot of some of the pieces. So really a major movement and why we celebrate Pride in June has to do with the Stonewall riots. and specifically transgender women of color, Sylvia Rivera, Marsha P. Johnson, really fighting for the rights and saying we will no longer accept the police brutality and attacks against our community. So this led to a major movement in gay rights. We saw this really start in New York City, but we know it was also happening in other cities. For instance, San Francisco years earlier, Los Angeles, Chicago. So the community coming together and saying this is not acceptable and really started the major movement for rights. But we do see, right, a lot of struggles that the community had to overcome. So, for instance, in 1993, the Don't Ask, Don't Tell policy was signed into law, forbidding gay and transgender people from serving in the military. We don't even see this repealed until 2011. And then we don't see marriage equality happening in our country until 2015. As well, it's important to note that some of the other aspects that were happening in the healthcare field that impacted the community. So, for instance, it wasn't until 1973 that being a homosexual person was not considered a mental health disorder, as well as transgender people to receive gender affirming care still have to have a diagnosis of gender dysphoria, right? Some of that language is changing, but we're still seeing in order to get gender affirming care, you have to have a diagnosis. So that creates unique challenges for the community when it says your identity is considered a disorder. We see other historical aspects that have impacted the community as well. And in many places, while there may be federal or state laws, there are still not the protections or the means to fight discrimination when LGBTQIA plus people experience this around housing, employment, and healthcare. It's also important to note that there are unique challenges when we think about intersectionality. So the intersecting and compounding impacts of discrimination based on either your LGBTQIA plus identity, your race, your ethnicity, if you're aging with HIV or living with a disability. And so when we think about Alzheimer's disease and why this might matter, many of the unique pieces in terms of successful aging, LGBTQIA plus people have not had the same opportunity. So one of the big pieces is economic security. One of the ways that wealth is shared through families is through marriage. And so we don't see for many elders that they could not enjoy this until after 2015. Social connections. I've shared that many people were ostracized or excluded by their families when they came out. And so what's unique for the LGBTQIA plus community is a reliance on chosen family, especially when we think about who are caregivers for LGBTQIA plus people. And then I've shared some of the historical, but even today, issues around discrimination for LGBTQIA plus people in healthcare. Many states are passing bans that are meant to restrict access to gender affirming care for youth, but we're actually seeing that many states or healthcare providers are fearful and they apply these laws to all transgender and gender diverse people. So a lack of competent and inclusive healthcare that's affirming is a huge challenge for the community. The community is growing in terms of LGBTQIA plus elders. We know that it is more than 2.7 million people who are age 50 and older, but none of our national data asks about LGBTQIA plus identity. So the estimates are quite crude. We know over 1 million are age 65, which is a unique piece when we think about risk factors for Alzheimer's disease. The community is quite diverse, so at least 1 in 5 identify as a person of color. And as I've shared about some of the historical impact, many LGBTQIA plus older people are living in poverty, so at least a third. So these create unique challenges for the community when we think about things like health disparities, higher rates of depression in the community, having less access to support services in terms of caregiving. So they're less likely to be married or have children. right? And they still today experience barriers to healthcare. So I want to shift gears and share with you a little bit about what do we know in terms of the current research. The first study really that I'm grateful for because of the Healthy Brain Initiative comes from the CDC in terms of the behavioral risk factor surveillance system. So I published a study with colleagues at the CDC in 2021 that highlighted that LGBTQ plus people are more likely to be experiencing subjective cognitive decline. So this is that they were reporting, right, that they were having confusion or memory loss in the past year that was happening more often or getting worse. And we look at those estimates, it's about 1 in 7 for LGBTQIA plus people that are reporting these problems with subjective cognitive decline compared to around 1 in 10 for non-LGBTQIA plus people. So a major concern when we think about this. The other issue to point out is that asking about sexual orientation and gender identity was optional, as well as the subjective cognitive decline questions. So here we represent data just from 25 states of people that are age 45 and older. When we look at the concerns in terms of subjective cognitive decline, here in red, I've highlighted the subgroups within the LGBTQIA plus community that were experiencing greater concerns. So we see higher rates for lesbian cisgender women, nearly 17%, as well as over 17% for bisexual cisgender individuals, nearly 17% for people who identified their sexual orientation as another identity but were cisgender. And then we see quite high rates for transgender people of all sexual orientations, so over 17%. As part of the subjective cognitive decline module that was included, they asked about how is your subjective cognitive decline impacting your everyday? And so for LGBTQIA plus people that were experiencing subjective cognitive decline, we see that they were more likely to report that they were having to give up their day-to-day activities, that they were needing more help with doing household tasks, as well as it interfering with their ability to stay social, work, or volunteer. And so many of these impacts we often see in some of the early markers when we think about mild cognitive impairment. So we do believe that some of the subjective cognitive decline that LGBTQIA plus people were reporting about were quite severe in terms of its impact on their daily lives. What we did not find a difference, and I think that this has a lot to do with stigma around an Alzheimer's or related dementia diagnosis, is that among both LGBTQIA plus people and non-LGBTQIA plus, greater than 50% did not talk to their healthcare provider about their memory loss symptoms. So a major concern that I think we have some work to do in terms of addressing the stigma, but also educating providers to assess about memory loss among LGBTQIA plus and non-LGBTQIA plus. Some other work that was led by my colleague, Dr. Ethan Cicero, looked within the BRFIS at additional years for those that asked about gender identity. And I want to point out, specifically, he looked at people who identified as a racial ethnic minority. So American Indian or Alaska Native, Asian, Black, Hispanic, Latino, multi-race, or those who identified their race as another identity. And so I had just shared with you around the rates for LGBTQIA plus people was around 17% for the subjective cognitive decline, but we see it's over 20%, 22% for transgender people of color. So we believe that this really represents a unique challenge and an area when we think about targeting within the LGBTQIA plus community, we really need to be thinking about intersectionality and our transgender community members. Some other work that we've done, one of the first studies where we looked at intersex adults across the US back in 2018, we also included some questions from the BRFIS that asked about memory loss. And so this study, we reached 198 intersex adults. These are individuals that had been diagnosed by a healthcare provider with an intersex related trait. When we look at reporting problems with memory and concentration, now this is not population level, so we can't say it's necessarily representative, but over 40% reported problems with memory and concentration. So we believe this is another group that really would benefit from both education, but screening and targeting. So I want to share some work that has been supported by the Alzheimer's Association, but also through the National Institute on Aging as part of a career award that I have finished up. And this study leveraged some of the most unique data that we currently have, looking at medical record data from Kaiser Permanente in Northern California. And so you see here on the map the regions that are represented as part of Kaiser. So in this, as part of the research program for genes, environments, and health, over 2,000 Kaiser members who were age 60 and older gave permission to utilize their medical record data, as well as completed questions about sexual orientation. So represented in this, we had over 4,300 sexual minorities, so lesbian, gay, and bisexual individuals. And we looked at ICD-9 codes from their medical record from 1996 through 2015. And in this, what we found was at baseline in 2007, around 7% for sexual minorities had a diagnosis of dementia, compared to 9% for heterosexuals. But what was really unique is that the sexual minorities were younger, about 2 years younger compared to their heterosexual counterparts. And what we found that was unique is that they were being diagnosed about 1 year earlier than heterosexual people. So a potential signal. When we looked longitudinally at the data, we found no differences for gay and bisexual men compared to heterosexual men. But where the concerns lied were for lesbian and bisexual women compared to heterosexual women. So we found that 23% higher odds of a diagnosis of dementia for lesbian and bisexual women. So another area that we believe deserves greater concern. We did adjust these looking at comorbidities, depression, gaps in healthcare, age, race. So those were considered in our model. Another study that leveraged in 2015 looked at Center for Medicare, so Medicare beneficiary data, and looked at those that had a listed in their medical record of accessing gender affirming care. And they looked at dementia just from the medical record, and we found that 18% of transgender people had a diagnosis compared to 12% for cisgender people, and everyone was age 65 and older. A recent study updated these numbers and looked at Medicare beneficiary data from 2008 to 2017, copying what was done in 2015, and we see even higher rates for transgender women and men in terms of diagnosis of dementia. So about 1 in 5 transgender people were diagnosed with dementia. So we believe this is another group that really is a major concern. We've also seen examples of higher rates of cognitive impairment when we look at national studies. So 2 of the Health and Retirement Study and the National Social Life Health and Aging Project looked at either same-sex couples, because at the time the Health and Retirement Study did not ask sexual orientation. In both of these studies, they found an 80% higher odds of cognitive impairment for lesbian, gay, bisexual people. And so we believe, again, this is a signal showing a greater concern when compared to heterosexual people. And areas that I think we really need to be thinking about when I shared about discrimination. So we see Among transgender people, we looked within the PRIDE study. It's a national study exploring the subjective cognitive decline questions from BERFIS, as well as experiencing discrimination in medical settings. And we see that transgender people who are reporting subjective cognitive decline also report that they're more likely to experience discrimination. And we believe that this represents a unique barrier when we think about screening, but also access to prevention and treatment for the transgender community members living with dementia. We also see a similar pattern. We did a study leveraging Fox insights around Parkinson's disease, and we also see greater discrimination for LGBTQIA+ people living with Parkinson's, as well as heterosexual women living with Parkinson's. So I shared a little bit about the unique challenges around caregiving, and I want to just point out that, again, there are major challenges. Those LGBTQIA+ people who are fortunate to have a caregiver often have unique challenges. Caregivers are often providing really intense levels of care, helping with wound cleaning, giving medications, bathing, a lot of really difficult caregiving that's a major burden to them. As well as we see a greater demand for caregiving for LGBTQIA+ people, with expectations of about 1 in 5 non-caregivers becoming a caregiver in the next 2 years. We've heard about concerns around long-term care settings, so many people are fearful what will happen to their care recipient, as well as just the burdens to the health. We know that caregivers experience unique healthcare challenges and access to preventative care, as well as maintaining their health, and we see these challenges happening for LGBTQIA+ caregivers. So a colleague of mine, Dr. Joel Anderson, did a study looking really at LGBTQIA+ caregivers who are caring for a person with dementia. And some of the big pieces that stand out is we see a large number living in a small town or rural community, so a third of them. We see that a third of them are experiencing economic challenges, finding it very difficult to afford the basics. Most of them do not use respite services or transportation services. So again, the impact of discrimination when we think about the use of long-term care services. I want to just give a shout out for a little bit of work that colleagues are doing. So first, from the University of Minnesota, Dr. Rosser and Dr. Shippey are leading a study that's funded by the National Institute on Aging that's testing an intervention in long-term services and support settings to look at ensuring that LGBTQIA+ people living with dementia can receive really welcoming care from the long-term care workforce. And so this is a study that is currently happening, and they're rolling it out to 62 facilities in Minnesota. So something for us to watch for. As well as you're going to hear a moment from colleagues about the incredible program, Club 75, or the Open House Unlock Community Day program. This, along with my colleague, Dr. Ye, we've been really evaluating it and looking at the impact of it. What's unique is this is a adult day program that was co-designed by the LGBTQIA+ community. It's really incredible, and I'm excited for you to hear about it in a minute. So I want to share really some of the best practices around the collection of sexual orientation and gender identity. And as part of a partnership with the Alzheimer's Association, but we have an LGBTQIA+ special interest group, we really worked hard to get the National Alzheimer's Coordinating Center as part of their social determinants modules to start recommending that all of our Alzheimer's disease research centers across the country ask about sexual orientation and gender identity. And so I just give a snapshot of the form that we have gotten implemented, and we hear that this is rolling out very soon. And we're just so grateful for the support of the Alzheimer's Association to get to do this work. So I want to close with just sharing with you some of the current research that I'm doing that'll be coming, just so you'll know what's some of the current focus of the work. So first is our Rainbows of Caring project. And this project is really looking at redesigning the way that we measure LGBTQIA plus caregivers to ensure that what's out there, the tools, the measures are truly inclusive, that they can accurately capture the experiences of our LGBTQIA plus caregivers of people living with Alzheimer's. And so we're currently in our second year, about to start our third year. And so we'll be rolling out these new measures in the future and testing them. And so that's what we're looking at doing in the future, as well as another federally supported research registry for the LGBTQIA plus community is the RISE registry. This is a registry that both LGBTQIA plus people with memory loss, caregivers, and researchers who want to work with the community can access this registry. Finally, I'm in the last year of a study called the Stonewall Generation Study. This is supported by the Alzheimer's Association, where we're actually looking at objective measures of cognition and looking at risk and protective factors within the LGBTQIA plus community. I also have a study that's wrapping up on Parkinson's disease called Parkinson's Research with Inclusion, Diversity, and Equity that's supported by the Michael J. Fox Foundation for Parkinson's Research. Finally, a study that is coming very soon, we're really excited about, is called Rainbows of Service. This is supported by the Department of Defense, and this is going to be a study that looks at the needs of all veterans with a focus on LGBTQIA plus veterans and caregivers to look at their unique needs and concerns. And so this will be coming soon. So I just want to thank my collaborators for supporting this work, as well as my funders. I have no conflicts of interest to report. And that is the end of my presentation.
My goodness, Jason. I want to thank you for on multiple levels. This impacts my family, those people I love, but you've given it such a deep dive in a short period of time, and that needs to be acknowledged. I think the information we've received has really impacted all of us here on the council. So what I'm going to do now, we're going to go on to your other colleagues, right? People based in the San Francisco Bay Area, where I'm from. But more importantly, they've been acknowledged as having programs instituted for a number of years. They started in San Francisco's Chinatown region, addressing the needs of that population, the Asian populations, and they've evolved to embrace a variety of underserved communities in that area. So I'd like to welcome Sandra Rivas, who is the Director of Programs of the Unlock. And then following after that, we'll kind of keep it rolling into Dr. Jessica Ng. And she is in charge, the Medical Director of the PACE program. So Sandra, take it away.
Good morning, everyone. I'm going to go ahead and share screen right quick. See if I could. Can everybody see my slide? Okay, cool. All right, so my name is Sandra Rivas. I'm the Director of Senior Programs over at Unlock, and I'm co-presenting with Dr. Jessica Ng. We have no disclosures, and I just want to give a quick kind of introduction to Unlock. Unlock was founded in 1971 as the founder of the PACE program, which is the program of all-inclusive care for the elderly. Over 50 years ago, Mary Louise Danzig and Dr. William G. co-founded Unlock on the principles of accessible healthcare, supportive services, housing, where necessary for the frail elderly to avoid unnecessary institutionalization. Today, we continue to carry forward their mission with innovative programs, policy, and advocacy to help all seniors to stay healthy and active and connected to their communities. Unlock operates a continuum of care of services. We operate the largest senior center in San Francisco through Unlock 30th Street Senior Center with community engagement programs, nutrition services, social services. In the last year, we have also launched CalAIM programs, enhanced care management, and medically tailored meals. And then today, we're going to talk about Open House plus Unlock Community Day Services, which is the first LGBTQ plus a licensed adult day program by the Department of Social Services. And as Jason mentioned, this program was created for and by the LGBTQ plus community. Unlock partnered with Open House SF. So Open House builds community by centering the voices and experience of LGBTQ older adults. Open House empowers San Francisco Bay Area LGBTQ older adults to overcome the unique challenges they face as they age by providing housing, direct services, and community engagement programs. Our partnership with Open House started in, I would say it starts in 2018 when we decided to create the LGBTQ plus program, but it was much more prior to that. What we did is we actually partnered with Jason and his team to create a needs assessment to guide us into what were the needs of LGBTQ seniors in San Francisco. And we'll go into a little bit more of that. This is a little bit of the timeline. We launched our program actually in the middle of the pandemic in October 2021. We became a licensed adult day program. We stood up the program. We also the seniors, as they came into our program, labeled it Club 75, right? As we move forward, we also became an alternative care setting for PACE. So a little bit about the needs assessments and key recommendations. There was focus groups, surveys, etc. at the time. And this was the key recommendations to us to create a one-stop shop program with case management, better linkages to healthcare LGBTQ identifying staff, use of trauma-informed care approaches. We should be providing inclusive services and design social programs based on the interests and cultural backgrounds of diverse LGBTQ seniors. And the program should be convenient, affordable, sliding scale, and customized to the holistic needs of LGBTQ plus seniors living in San Francisco. With that, we created Club 75 or Community Day Services. So CDS provides participants who desire LGBTQ plus culturally affirming program, activities, nutrition, transportation, and caregiver respite, comprehensive services more than just drop-in programs. It also provides a pathway for participants who may need higher levels of medical care to become PACE enrolled or program of all-inclusive care. And then CDS provides frail participants who participate in PACE an alternative care setting to receive these services. So what that means for some of our clients is that they'll come to our day program, receive socialization, nutrition, respite services, but receive their medical care in a PACE setting. Eligibility and cost of relocation. The eligibility is to be 55 or older. You can benefit from assistance with daily activities, benefit from a supportive, affirming environment, and needs assistance with personal care. Costs for participants are based on a sliding scale and we also provide financial assistance through a lot of fundraising and also grant support, etc. We also take health plans or long-term care insurance that offer an adult day program benefit. And we are located at Open House Campus, which has a senior center program, the adult day program, and then also LGBTQ plus senior housing. I will go ahead and turn it over to Jessica.
Hi, everyone. So I just wanted to talk a little bit about what PACE is. So PACE is called Program of All-Inclusive Care for the Elderly. As Sandra said, that it's been around for over 50 years. Unlock founded it really with the idea of the Chinese American community needing something to try and keep them from being institutionalized. And since then, Unlock, as the leader of PACE, has been trying to address other underserved communities and how we can keep them from being institutionalized. Now, PACE is federally funded through CMS and is in over 30 states and I want to say 180 programs nationally. So I want to talk a little bit about what PACE is serves specifically and around and why it's good for people who are at risk for dementia and also underserved communities. So really what PACE is a comprehensive person-centered care to support individuals who are eligible for nursing home care but want to remain in their communities. And really what the key is care coordination. If anyone who has had a loved one going through the healthcare system is how it talks about how fragmented it feels, how many phone calls, how many different organizations you need to work with to kind of put everything together. So Unlock and PACE, what we do is all of these things that are pictured here. So really at the center is the participant and the family, and we coordinate all of these things. So at the heart is we have a primary care clinic that is co-located with adult day center and services for an interprofessional team with 11 different professions. So including your social worker, your physical therapist, your nutritionist, and the place where you socialize, which we know decreases your risk for dementia. They're all under the same roof. We provide the transportation. We coordinate with your pharmacy. We coordinate all of your medications. We pay for usually contracted, with the labs, specialists, hospitals. If you need temporary care at a skilled nursing facility, we coordinate all of that. If you need home delivered meals, all of it together, which in a coordinated way which we think is what older adults need. It's trying to coordinate between like 6 different agencies that deliver care is increasingly really difficult. And really the focus is on when that's coordinated, that is preventing bad things from happening because the communication is better. It's all under our roof. So we are as what like a health plan that delivers all this, so full risk. So we can do things like, hey, if we think that like one of the examples I like to give is we had an older adult who almost started a fire in their building because they were cooking something, left the stove on, which where I previously worked is your one-way ticket to a nursing home. You can't live independently anymore. But because we could, let's say, like do frequent visits for a week, we're like, hey, we're gonna check in weekly, see how things are going. We're gonna take the knobs off, get them the family's going to get them a rice cooker, which is what they were trying to cook, and see if they can continue to live like in the community and watch them closely. And that person, 2 years, is still living in an apartment by themselves rather than being institutionalized. So that's the kind of personalized, high touch care that we can do when we are experts in older adults and can keep a really close eye on people and understand risks versus benefits of institutionalization. Right, next slide, Sandra. And so this is just really a look at what a different representation of all of the different professions that are under the care. So we also provide caregivers to go into the home in addition, and activities. I was like, what else did I not mention? Oh, home care. So the home care nurse, physical therapist, if they need to, or we bring them into the center to deliver that kind of care. All right. I'm going to turn it back to you. Oh, now I have one more slide. And so PACE overall has been studied that it's extremely high satisfaction. So you can imagine if you have one portal to talk about most of your care, we have excellent care in terms of our preventative care. We have over 80% of our participants are up to date with the latest COVID shot, which you can imagine is like, I don't know, it's like the 6th round of COVID shots, but we continue to do that, and our comparator is about like 30% in nursing homes in our state. So we do deliver better preventive care than other systems, and we also reduce hospitalization by doing things like being able to, in our clinics, be able to see people daily when we know that things aren't going well, to prevent them from being hospitalized. And that over 90% of our participants continue to remain in the community, even though they're eligible to live in a nursing home. All right, now back to you, Sandra.
Thanks, Jessica. I wanted to kind of go over like Club 75 member profile. 95% of our clients identify as LGBTQ+, 22% are HIV survivors, 12% trans, 22% have Alzheimer's or related dementia, 29% are dual enrolled in PACE, 62% do require financial assistance to enroll. We have a small percentage of those who are private payers. And the biggest for us to highlight is that 81% of our clients are single with limited circle of support. And so our staff become that circle of support and advocates or care navigators in the community as well. We have served over 28 unduplicated clients in this last fiscal year. And just a little bit of like the cultural diversity that you see in the room, but also we make it a point to hire staff that are representative of the community, also with a language capacity, as we meet a lot of our clients that have that intersection, right, of identities. They can be both, Afro-Latino, a veteran, Spanish speaker, or a trans woman of color who is also a HIV survivor, and an advocate in community, and then have staff also that have that same lived experience and really can connect with our clients. Another thing that I wanted to add through our partnership with Open House is that they provide a robust training program for staff in service of LGBTQ elders, both with culturally affirming care, dementia and LGBTQ focus, trainings for our staff as we see those clients come in through our doors. One of the last things I want to leave you with is some recommendations from us and what we're seeing. We would like to recommend, like in PACE settings, but also in launching either adult day programs and expansion of PACE LGBTQ plus adult day programs, and enhances the program of all-inclusive care for the elderly to deliver comprehensive cultural affirming care for LGBTQ seniors, enable them to stay in their communities with appropriate support and activities, nutrition, transportation, and caregiver respite, a support of community-based programs and partnerships. So fostering collaborations like the one between Unlock and Open House SFs to create specialized adult day programs or programs for LGBTQ seniors, and conduct needs assessments and tailor those programs to specific health challenges of the demographic and evaluation in those communities. Implementation of culturally tailored programs and designing inclusive services and social programs that reflect the diverse cultural backgrounds and interests of LGBTQ seniors, ensuring that care resonates with their identities and needs. And also a very, very big one, as we know, with like adult day programs, most of them are private payer. And so ensuring financial accessibility and maintaining the affordability either through sliding scale fees, financial aid, or making programs that are accessible to LGBTQ seniors across various economic backgrounds. If you would like more information about our program, I just want to leave our contact information here, but also similar to Jason, some acknowledgements of just the leadership that, and also Jason and Jarman, who've been very instrumental in the research and with the needs assessment evaluation, and are continue to actually work together in actually standing up this program and in creating a program for and by the LGBTQ plus community. And that is it for me.
All right. Sandra and Jessica, I want to thank you for that. I am overwhelmed by the amount of just out in the community you are, the welcoming nature of it, and the fact that you allowed the people with lived experience to help you develop this program. I think that even though, there are those advocates out there, whether it be people actually living with the disease or their care partners that are very willing to give their time, it is sometimes, in my experience, a rare occurrence that programs are developed with their input. So that to me is just incredible. And so hopefully in the future, more programs nationwide, whether it be in to meet the needs of this population or every population with dementia, that they have this level of input. So I appreciate it. I'm now going to turn over to my fellow council member, Fawn Cothran, to have Fawn lead the question and answer period.
Thank you. I also want to echo my thanks to you, Jason, Jace, and Sandra, as well as Dr. Ang. Thank you so much. I really was struck by so much that has been said today. Before I open it up for questions, I just want to share on a personal note that it's really exciting to hear what's happened with PACE and Unlock. When I was a grad student is when I first learned about PACE, and that was in the definitely early 2000s, and to hear how much has happened and how it's evolved and how it has continued to become even more inclusive is just really inspiring to hear. And I just want to commend and say thank you for that. So I do have some questions, but before I go into mine, because similar to my colleague Joanne Pike mentioned earlier, I do have questions in my back pocket, but I do want to ask if there are questions for the presenters before I step into mine. And I do see that we have one from Adrian, and then I saw Helen, and I'll make sure to pay attention to those online as well.
Thank you. Excellent presentation. I did want to mention in terms of Unlock, one of the other co-founders, Jenny Chin Hansen, who's done some remarkable work. My question is, I know with Unlock being a PACE and that CMS now has made this possible to be extended to many other states, because it's a niche population of people who are certified to be in nursing home but receive services in the community. I wondered if that was the reason that your number was 28 unduplicated members. Is it because of there's a wait list? Is it because the criteria is so narrow? Is it because of publicity? Can you clarify more? Is the Unlock, are they also PACE, or is it just adult daycare? Thank you.
Actually, both. So we have clients that are non-PACE members and PACE members. And I would say really people, I think now things are shifting, but we launched in the middle of the pandemic. And so people, one, didn't know that this program existed. And then, that there was a lot of impacts on the pandemic in terms of the way seniors and their family members were actually engaging in just programs in general, I would say. And so a lot of it had to do with socialization of the program. Fortunately, and obviously in 2021, there were starts and stops with adult day programs. They were considered essential, then non-essential. They weren't in person, but all of our services are in person. So there was a little bit of a sputtering, I would say, in the start, but we stayed committed to it. And then also, as we were building out the program with our partner, it really was in the socialization of the program. And now we're seeing more growth, but we do have clients that are both non-PACE and PACE in the program.
And I just want, sorry, I just wanted to sort of add on to that, as for anyone who is trying to build programs in underrepresented communities, it's not easy. And I think like our we have a long-term commitment to this community, that we're not going anywhere, and that they're that we're going to continue to be partners, but and step by step we're getting there. But and this is that's part of our advice to other programs who want to do similarly. That it's certainly not easy, and then also trying to understand the individual needs of the specific community that you're trying to serve. Sorry to interrupt.
Thank you. That really does tie into the question I had. In terms of the numbers being small, I couldn't tell if it's the challenge, as you just said, in terms of the group of those, COVID and stuff like that, or is it's not a matter of acceptability in the community. It's a matter of finding the right people, or is it finances, or what makes the number 28 as being small when other groups may want to consider replicating this? What are the barriers that they're going to run into? Can you speak more to that? Thank you.
I think when it comes, well, there's a couple of things I can think of. Is one, socializing your programs and people understanding what your programs are. Our program is a little bit complex. When you describe you're a standalone adult day program, but we're also an alternative care setting for PACE, and we also provide financial assistance, and we're not a drop-in service. And so I think is one, messaging in your program, socialization, but also partnering with organizations, LGBTQ facing organizations, and then others within your communities, right? And where are LGBTQ elders or LGBTQ elders and their families looking for services? Where are they engaging in services? We've had to pivot many times. We have found that most of our clients are, we had this initial thought process, we have 2 residential LGBTQ apartments right next door to us with like 100 units. And we thought people were just going to come down, engage in the program, etc. And that was not the case. We're actually finding that more of our clients are actually living in the community and needing those services. And a lot of them have not been availing themselves to services at all. And so when a program like this comes, it's like, wow, I didn't know you existed. You have affirming care. It's LGBTQ led. You have affirming staff. Within an LGBTQ organization, it becomes a surprise for folks, even here in San Francisco, where you wouldn't think that that would happen. Also, I think some of the things that like some of the family members or even clients themselves bring to us is that fear of rejection too, of coming into programs and, the way they have been treated in other institutions, right? Is this something that I trust? Do I trust this organization? Do I trust the staff? How do I feel here? Who is in the building? Do they look like me? I mean, these are things that I get from our clients. Are they representative of me, right? And so I think engagement in programs, especially when you're starting, when you only have 5 people, right? You think of that 5 or 10 people as you grow more and more, and people understand, yes, we do serve HIV survivors. We intentionally serve them. We intentionally serve trans elders. We are intentionally serving those with cognitive impairment, and then providing support services for their partners, et cetera. Then I think it's just building that out, I would say. I don't know, Jason, do you have anything you want to add to that? I see you nodding.
One follow on to that before you answer Jason. Because there's a national PACE community, is there plans for replication of this among those other PACEs?
That is our goal and our hope, that we, just like the PACE model has been replicated, we hope that they would still also take this like focus of LGBTQ focus. And I do think that there is that focus, at least at our last national PACE conference, of DEI, and also just focusing in the LGBTQ community and taking this program and replicating it in different models of PACE centers throughout the US.
Go ahead, Helen. Thank you.
Hi there. That was a robust discussion, and I know we'll get into it deeper at some point, but I wanted to focus on those high numbers, of course, of living alone. When because I actually am a support group facilitator for caregivers of individuals living with Lewy body dementia. And because I'm in the Greater Bay Area and cover the North Bay, and that literally takes us from the Sonoma County line all the way up to the Oregon border. But even so, I have people out of San Francisco that reach out, or the Greater Bay Area. And I've had numerous outreach from individuals that would identify as LGBTQ+, and their specific needs, some that live alone, fearful that they're going to be removed from their homes. And so, at least from my perspective, what do you do in the area of caregiver training? I've taken an approach, just as a sidebar, I've taken the approach that I have what I call family meeting. And so via Zoom or face-to-face, we'll bring in their, rarely is it a next of kin, it is their friend community. And the last one I held was a member of 12 friends. We spent 2 hours, 1 hour on education. What is the brain? What is Lewy body dementia? And then the specific needs. And then an hour of exchange just for them to share. And so I just wonder, are those types of services or outreach to the chosen family of your participants offered, or is it something that could be considered?
I would say it's offered through partnership. We definitely in the partnership with Open House, not only do they provide support groups for those who are either living with either dementia or other HIV survivors, etc., but there's also family and friend support groups as well.
Thank you.
Yeah, and we often use even the term, Helen, when we're thinking about it, it's like care circles, right? So for many LGBTQ plus people living with dementia, they may not have what we would consider like that primary caregiver. They have a bunch of chosen family friends that are coming together and navigating. This person does doctor's appointments on Tuesdays and Thursdays, right? This person does meals. This person does grocery shopping. This person, right, is the fun, like takes them to social outings. So it's a really unique when we think about networks. And I wouldn't say these circles are limited to LGBTQIA plus people, but I think that they're really unique in terms of their reliance on them. And so we've definitely, I know we've talked about this with Club 75, and many of the participants rely on that. But what's unique, I think, of the program is they're almost creating these care circles. They're creating friendships and relationships and healthcare providers, and right, and they have caregivers, paid caregivers there that are helping to navigate pieces. So it's really unique.
Thank you. I am just going to see if there are any other questions around the room. I don't see any, and I'm not seeing anything online. So one question that I did have for you, Jace, was regarding something you mentioned about discrimination. I'm particularly interested in discrimination and how it relates to cognition. And I know you mentioned that there's work that's been done or being done related to the impact for LGBTQIA plus individuals, but I'm curious about, are we seeing anything or any impacts with discrimination for those care partners or chosen friends and family who also may have experienced discrimination, and how that impacts their cognition? Is any of your work starting to tap into that? And if so, could you speak on that?
Yeah, so we are looking at that. I think that is one of the reasons where I had shared that number of the low number that are using respite or any types of long-term care services, right? It's a fear of either they've experienced discrimination in the past with healthcare, so there's a reluctance to even go out there. But when we talk to caregivers, and many caregivers are maybe caring for a biological family member as well, and they will go into a long-term care setting and be misgendered, or right, they'll use the wrong pronouns or other, just other making assumptions about the relationship. It's two women together, right, and making an assumption that you're her sister and not her partner, right? And so those are really unique challenges. So we are looking at it, we're measuring it, and we definitely see that that is a major impact on the reluctance to seek out services, the lack of trust of healthcare providers, a lot of it. So we're looking at it, and I mean, this is why policy matters so much. One is that protection, but also there's still just the challenges, and this is why we need the program like Club 75, right? Is because LGBTQ plus seniors don't want to go to an adult day program where they're going to be maybe mistreated by the other participants that are using the program. And so it's a really unique piece that we're looking at.
Thank you. We have another question in the room. Go ahead, Adrian.
I wanted to stay with you. You mentioned in your data the high prevalence of persons living with dementia caregivers in rural settings.
Mm-hmm.
That would be a really unique challenge of trying to provide access to services. Can you talk more about what that population and some suggestions there?
Yeah. So we know from the broader research for those living with dementia in rural communities, barriers to care, the lack of services and support. You may have a long-term care services adult day program that's more than an hour drive from your home. So it's just not feasible. What if you're living alone and you can't get there? But in terms of for LGBTQIA plus people, I think there's, the story's not completely, I wouldn't say, there are a lot of strengths. In rural communities, there's a major focus on building these ties and investing in relationships. And so we do see some of those strengths for many LGBTQ plus people living in a rural community. They've already created networks because they had to because of the distance. Um, I think of something that was really unique during the pandemic that happened through SAGE, the National LGBTQIA service organization. They created like a buddy network where people could call. I actually volunteered during it, right? You could call and talk with an LGBTQ plus elder that was homebound or living in a rural community. So this, I think what would be really unique is for us to study this more and look at the role of this. We see the impact of faith-based communities as well in serving rural communities, so that's important. But there's unique pieces for LGBTQ plus communities that has been understudied, and we need to look at it more. So these are great. It's an area that really we need to look more into.
Okay, I don't see any more questions, and I'm standing in the way of us breaking for lunch. So I will actually pause and turn it back over to Helen in case there's anything to wrap up.
No, I think at this point, I think we've delved into it a lot. What I really, Adrian, you've asked some very delving questions, which are great, and things that'll give us some perspective as we look to the next 10 years of NAPA. Because what we recognize here is you're one minority or multiple minorities under one umbrella. And yet this is going to translate to many of our minorities. Discrimination is real. Exclusion is real. And so it's vital that, even someone with dementia, with a dementia diagnosis feels excluded. They feel isolated. That's one of the first things that comes crashing down. No one's going to accept me for who I am. And yet they didn't change from yesterday to the date they got a diagnosis. They are the same individual, just it's maybe a different chapter in their lives. So I think it's vital that we learn from you and that we be able to translate the data that you've put forth along with expanding programs like Unlock and listening to people's stories. They are vital for us to understand, to open up our level of empathy and compassion and move forward. So yes, it is now time for lunch break, but I want to thank my Californian friends for getting up early to join us today. That meant a lot. And we will look forward to speaking with you again in the near future.
Thanks so much.
So we will break now and reconvene at 12:15, from 12:15 to 1:15 Eastern Time. Thank you.
Produced by the U.S. Department of Health and Human Services.